Good evening to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker doctor for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. N.K. Soni. Sir is MD, FRCP Glasgow, FACP USA, Director Academics and HOD of Internal Medicine at Yatharth Super Speciality Hospital, Greater Noida. Without the help of Sir, we will be taking a close look on today's topic, which is managing hypertension during pregnancy is a challenge. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you. Thank you very much for this kind introduction and giving me this platform to interact with my colleagues who have joined this evening for a very important topic, which is very, very challenging and very interesting also for all the clinicians who are dealing with the practice of managing hypertension and particularly during the pregnancy in females. Well, to begin with, I would like to start my talk and would like to emphasize that science and art of managing hypertension in pregnancy is very challenging. This is challenging because of the two aspects. One, that it involves two lives, one of the mother as well as one of the fetus. So two lives are involved with this disease process where increased morbidity and mortality is determined and health of the mother and the child both is dependent upon the meticulous management of blood pressure during the pregnancy. That is one part. And the other part is a challenge for the clinicians because there are less number, only a few molecules of managing hypertension which are safe to be given during the pregnancy. You can't give all the medications which have been listed in all the guidelines, whether national or international guidelines, as first-line antihypertensive drugs, second-line antihypertensive drugs, and others. There are only limited number of the drugs which are safe to be given there. So it becomes very challenging for the clinicians also to control the blood pressure in the mother during the pregnancy at a desired level so that she can have a delivery without any complication and the health of the mother and the child is preserved and they are healthy. So these two aspects we always have to keep in mind while discussing this subject of managing hypertension during the pregnancy. And if you see the incidence wise, it has been estimated that hypertensive disorder of pregnancy, it complicates around 5 to 10% of the pregnancies. Now, this number seems to be very small, that 5 to 10% only. But in a very populous country like India, where 140 million people they live, and there are increasing number of this complication because of many other factors of cardiometabolic diseases which are present in the younger women nowadays, whether it is the advancing age or late age of marriage, or the increasing incidence of obesity, then polycystic ovarian disease, which is characterized by insulin resistance. So, and the pregnancies, which are multiple pregnancies, they all complicate and then the association of hypertension and diabetes, which are comorbidities, which are usually associated in elderly girls who are in the age of 30s to 40s. because of their eating habits, fast foods, smoking, and whatnot. So all these problems, they add to the development of hypertension in this population. And this 5 to 10% cases also forms a large number of the population and the patients. And that is why it is all the more important for the clinicians to understand the intricacy of managing the hypertension during the pregnancy. Now, my flow of chart, I'll be discussing about the hemodynamic changes, the epidemiology of hypertensive disorder during the pregnancy, even the pathogenesis we will discuss, then the diagnosis and classification and pitfalls in managing the blood, in measuring the blood pressure. That is also very, very important for us to understand. Actually, it's a practical aspect which we must know, because I consider that once you know the science, the measurement of blood pressure is also an art, and one should be perfect in that art to measure correctly the blood pressure so that you can manage it properly in your clinical practice. Then the management and the guidelines, and not only that, even post-delivery management is also equally important if we want to give a good, healthy life to the mothers. So, my dear friends, if we start with epidemiology, sorry, hypertensive disorders in pregnancy, it is not a single entity. It is not only the chronic hypertension which is present during the pregnancy or before the pregnancy and goes beyond the pregnancy, but it is a complex multi-system disorder. It causes a lot of problems like preeclampsia, leading to complications like eclampsia, HELP syndrome, which is hemolysis, elevated liver enzymes, and low platelet syndrome, and acute renal failure with pulmonary edema, stroke, and whatnot. So it increases the morbidity and mortality of mother and the child altogether if it is uncontrolled during the pregnancy. Severe preeclampsia and these complications are major causes of maternal and perinatal mortality and morbidity. And among all the maternal deaths, it is estimated that 19% deaths are due to hypertension in pregnancy. And this was estimated by WHO in 2014. And today, this figure must be more than around 20% or so. And even the National Eclampsia Registry by Foxy has revealed that the incidence of hypertension during the pregnancy to be high, with a substantial incidence of eclampsia, which is present and which increases the morbidity and mortality of the mother and the child. So the incidence which has been estimated in India of hypertension disorder in pregnancy has found to be more than 10% as per the data collected by National Eclampsia Registry. And maternal morbidity, which is attributed to eclampsia, is around 4 to 6%. So in fact, in nutshell, we can say that it's a big problem, and the management has to be very meticulous, and at least it helps in healthy deliveries and healthy life for the mother as well as the fetus. The hemodynamic changes which occur in the pregnancy are very important for us to understand. There is a marked increase in the metabolic demand and hemodynamic adaptations that vary from trimester to trimester, in the first trimester to second trimester and the third trimester, and even during the postpartum period where it comes down to the normal. We should understand clearly the metabolic demands and hemodynamic adaptations. The major hemodynamic adaptation during the pregnancy are threefold. One, that there is an increased cardiac output. Second, there is an increased plasma volume. And third, there is a concurrent reduction in systemic vascular resistance. These three changes are remarkable, and these are rapid and dynamic changes. And the pregnancy, which is often considered as physiological stress, and because of the adaptation in the in the mother, because of these changes, that helps in a healthy delivery and a good life for these patients, because insufficient adaptation results in maternal and fetal morbidity and mortality to a large extent. Now, if I explain these changes in this diagram, you will appreciate that in the first trimester, usually there is an increase in the cardiac output, decrease in the systemic vascular resistance, as well as increase in the heart rate and decrease in the BP because of the vascular dilatation. Now, if we take each arrow as 10% increase or decrease, you can appreciate that in the first trimester, it is about 20% increase in the cardiac output with 30% decrease almost in the systemic vascular resistance and a little increase in the heart rate and decrease in the BP. In the second trimester, it is further aggravated. So, cardiac output increases to around up to 40%, and systemic vascular resistance decreases by around 40%, with further increase in the heart rate and decrease in the blood pressure, which persists through the third trimester as well. And in the postpartum period, then it comes down to a baseline. So these are the hemodynamic changes which occur from first trimester, second to third trimester, and these are dynamic changes which take place. And of course, that is why the mother's body should adapt to these changes and thus can have a good pregnancy duration or antenatal period. So with this hemodynamic changes, if we go for pathogenesis, that how does all these complications or pre-eclampsia or eclampsia they develop, we'll see that it all depends upon the health of the mother. Whether the mother is healthy, she's not having any comorbidity associated, but the determinant for all these complications are pre-existing maternal comorbidities, and there are non-modifiable characteristics like age of the patient, reproductive history, genetic and other immune factors for the risk of developing severe hypertensive disorder during the pregnancy. So variable contributions of underlying maternal and placental pathophysiological pathways, they result in heterogeneous phenotype of hypertension during hypertensive disorders of pregnancy, and the clinician must be aware of it, as well as the modifiable as well as non-modifiable factors which are associated with the mother's health in the antenatal period, which will determine the outcome of the pregnancy in these individuals. Well, if you see this dramatical presentation of the pathogenesis of hypertensive disorder during the pregnancy, the maternal pathway is determined by the comorbidities of earlier hypertensive stage in the pre-pregnancy stage, diabetes or CKD, which may be associated. Obesity is a very important factor which determines the outcome in these patients. Then age of the mother, race, multi-fetal gestation, even nulliparity, as well as genetic and immunological biologicals. These all determine about the hemodynamic, metabolic, as well as hormonal pregnancy adaptations and the outcome of the pregnancy in these patients. From the placental pathophysiology, it is the RAS stimulation as well as angiogenesis imbalance, which causes the release of inflammatory, pro-inflammatory markers, as well as inflammatory imbalance, which occurs in the mother, and it leads to an irreversible cell cycle arrest mechanism that leads to the systematic metabolic and functional decline, and may play a role in impaired angiogenesis and in leading to pre-eclampsia and eclampsia, and thus leading to morbidity, increased morbidity and mortality. Similarly, if we see the maternal pathway as well as placental pathophysiology, we'll realize that it all leads to the endothelial dysfunction, pro-inflammatory state with a pro-coagulation, which can affect almost all organs of the body, whether it is the liver with the impaired liver function test, or the blood cells with thrombocytopenia or advanced coagulation, or DIC even in the severe cases. In the brain, it can cause cerebral edema, eclampsia, or stroke. Heart may be, cardiovascular system may be involved, or most importantly, the kidneys involvement, glomeruloendotheliosis with the proteinuria, which is the hallmark of preeclampsia and eclampsia, with the placental infarction and placenta abruption, and all these things, they lead to, of course, development of proteinuria, and has been documented both before and at the time of preeclampsia diagnosis, which is the hallmark of preeclampsia and eclampsia and seizures, and leading to increased morbidity of the mother and the child. So this is all pathophysiology, the hemodynamic changes, which we must know to at least assess the problem and then manage these patients accordingly in our day-to-day clinical practice. Well, once we measure the blood pressure, there are few, as I said earlier, it's an art of measuring the blood pressure in the clinical patients accurately. And for this, there are a few points, clinical points, practical points, which I would like to emphasize upon, like improper cuff, where if it is too large, it measures the low BP little on the lower side from the normal. And if it is too small, of course, we can measure the higher BP. So the cuff size should be appropriate. The cuff placement should be appropriate, and the patient should be relaxed while you are measuring the blood pressure. Patient's position, arm support, everything. Even if the patient is full bladder, then because of the stress, again, there is a falsely increased measurement of blood pressure to the tune of around 10 millimeter of mercury. So all these factors should be taken into consideration, and then only we should measure the correct blood pressure and start the treatment if needed. And these are important for the clinicians to remember. Well, for the diagnosis and classification, the American College of Obs and Gynae, ACOG, has defined hypertension in the pregnant women when this systolic blood pressure is equal to or more than 140 millimeter of mercury, and diastolic blood pressure is equal to or greater than 90 millimeter of mercury on two more occasions, at least 4 hours apart. So actually in the clinic, when we measure these blood pressure, we should take 2 to 3 readings, and that too, we should guide our, or we should ask our staff to take these blood pressure readings at least after 3 to 4 hours from one another. And then in these measurements, the lowest the reading is probably the most accurate reading, because we must consider everything, that white coat hypertension and other anxiety factors whenever the patient comes to the clinician's office, and then it causes a false increase in the blood pressure. So if we take 2 to 3 readings, the lowest reading is always the more accurate reading in comparison to the others. ACOG further categorizes that severe range of hypertension starts when systolic blood pressure is more than 160 millimeter of mercury and diastolic is more than 100 or 110. And these becomes an emergency. We can't wait for 4 hours, and it is if it's measure 15 minutes interval, at least 2 readings, then without a delay, we should start the treatment in these patients. So this is the diagnosis and classification and measurements where we should do it. And then the classification. How do we classify the hypertension during the pregnancy? Well, there are 4 types usually which has been described. That chronic hypertension when the patient is hypertensive even before the pregnancy, and then the hypertension or high blood pressure persists even after 12 weeks of pregnancy, then it is called as chronic hypertension. The patients are chronic hypertensives and they need a treatment when this is present even in pre-pregnancy period. The gestational hypertension, we call it when the hypertension appears after 20 weeks of the pregnancy, then we label the patient as gestational hypertensive. Preeclampsia and eclampsia, these are when target organs of the body are involved, when there is a HELP syndrome or renal involvement or proteinuria with pedal edema. These are the conditions when we label it as preeclampsia, and when seizure also occur, we call it as eclampsia. Chronic hypertension, which is present before pregnancy, that can also be superimposed with preeclampsia and eclampsia if it is not controlled adequately during the early first trimester or so of the pregnancy. So these are the 4 types of classification of hypertensive disorder during the pregnancy. And as far as the incidence and prevalence is concerned, American College of Gynecologists that has classified that gestational hypertension is most commonly present, usually when it appears after 20 weeks of pregnancy, and it is present around 6 to 7%. And preeclampsia, when it is associated with edema, organ involvement, as well as proteinuria, the incidence is 5 to 7%. These are 2 most common type of hypertension which we encounter during the pregnancy in large number of patients. Well, this is the simplified classification of hypertensive disorders of pregnancy, that whatever I have explained it to you, that when systolic blood pressure is equal to or more than 140 millimeter of mercury, and diastolic blood pressure is equal to or more than 90 millimeter of mercury, we see the gestational age of the patient. If the blood pressure appears before 20 weeks of gestation, or it is present before the pregnancy of the patient, we call it as chronic hypertension. And it is also at the risk of developing preeclampsia or proteinuria and diabetes, proteinuria, pedal edema, as well as other organ involvements in due course of the pregnancy. So we should always observe these patients closely and treat their blood pressure. And then if the high blood pressure appears after 20 weeks of gestation, we call it as gestational hypertension. And if there is no target involvement, it is the gestational hypertension only. Whenever there is a target involvement, it may lead to preeclampsia. And if it is associated with seizures, it can cause the eclampsia, or it may be associated with HELP syndrome, which is hemolysis, elevated liver enzymes, and low platelet count. So that becomes a very serious condition for the life of the patient, life of the mother, as well as life of the fetus. So this is a simplified model of the same, that systolic, we should first measure the blood pressure, then we should see the gestation before 20 weeks, or persistent hypertension, which is persisted there for 12 weeks in the postpartum period also. Then we assess whether there is a target organ involvement or not. So preeclampsia superimposed chronic hypertension, or chronic hypertension only with the no target involvement. From 20 weeks of gestational onwards, it may be gestational hypertension, no target organ involvement, and preeclampsia with the target organ involvement, as well as proteinuria. And this is how we classify the hypertensive disorders during the pregnancy in the mother. Well, there are evolving evidences in the management of hypertensive disorder of pregnancy that if we treat, how much is the benefit like, and if we do not treat, what are we going to lose? So there is a Cochrane review which was done on 49 trials, and it was assessed that even the treatment of mild to moderate hypertension during the pregnancy causes a lot of benefit to reduce the risk of developing severe hypertension and the health of the mother and the child. And if we do not treat these, then it does not reduce the preeclampsia or preterm birth. There are chances of preterm birth. There are chances of maternal fetal mortality, which are increased. So there are evolving evidences to suggest that we should treat the blood pressure in pregnant women meticulously, and we should try to, reach to the target of blood pressure in these women of less than 140 millimeter of mercury systolic and less than 90 millimeter of mercury diastolic. So how should we manage? That is very, very important for us to understand for the clinician's point of view. For chronic hypertension, gestational hypertension, preeclampsia and eclampsia, all these stages of hypertension. Well, for medical management, the World Organization Gestosis has recommended that we should start the therapy when systolic blood pressure is equal to or more than 140 millimeter of mercury and diastolic blood pressure is equal to more than 90 millimeter of mercury. The target range is less than 140 by 90 millimeter to avoid hypertension, and that should be the at least between 130 by 80 millimeter of mercury to 140 by 90 millimeter of mercury. The three drugs which are very, very important, and only these three drugs most important, which are used very commonly. One is the labetalol, which is the first line medication. It can be started in the dosage of oral with the 50 milligram twice a day, where we can go even up to 200 to 1200 milligram per day in 2 divided dosage. And this is one of the preferred medication which is used in hypertensive disorders during the pregnancy. The other is calcium channel antagonist, that is nifedipine. Nifedipine should be used in a slow release preparation. That is important for us to understand that we do not want that blood pressure measurement, the treatment of blood pressure should be such that it should be a precipitous fall. No, it should not be a precipitous fall. It should be a gradual fall, but we should try to reach to the targeted level as soon as possible. It should not be within minutes. It can be in hours, but then it should be good control. So nifedipine in slow release preparation is preferred when baseline pulse is less than 100 per minute, because it causes some reflex tachycardia. So this drug again is a very good and safe drug for control of blood pressure during the pregnancy. And third is, of course, alpha-methyl-dopa. Alpha-methyl-dopa is usually the preferred antihypertensive in the early stages because this is not a very strong antihypertensive drug, but relatively safe drug, which again can be administered orally in 2 to 3 divided dosage from 500 milligram per day to even up to 2000 milligram per day, and is the safest of the antihypertensive. But the only problem with this is that now it is not very freely available everywhere, so that becomes an issue. But otherwise, these three drugs, labetalol, nifedipine, and alpha-methyl-dopa, these are the drugs which are safer antihypertensive drugs to be used in majority of the patients of hypertensive disorder of pregnancy. Well, we must also remember that the drugs which are contraindicated in the pregnancy, it is always our medical ethics that tells us that if we are treating a patient, if we are not able to provide a good benefit to this patient, at least we should not prescribe a medicine which is going to harm the patient. So the drugs which are contraindicated are ACE inhibitors and ARBs, which are otherwise first-line agents to be used in younger population for the control of blood pressure in majority of the patients, particularly in diabetes, if it is associated with, but in pregnancy, these are contraindicated because of the development of teratogenicity. Even beta blockers, because it reduces the heartbeat of the fetus also, that should be avoided. Even diuretics, because diuretics can cause little electrolyte imbalance as well as it can cause little dehydration where there is a decrease in amniotic fluid also and can be detrimental for the health of the fetus. So ACE inhibitors, ARBs, beta blockers, as well as diuretics, that these are really contraindicated in pregnancy, and it is always should be avoided. Even alpha-methyl dopa, it should be discontinued in the postpartum period to avoid the postpartum depression because it's known to cause postpartum depression in some of the patients. So it can be used during the pregnancy. But as I told you, it is not a very strong antihypertensive drug. So usually in early stages of the control of blood pressure, it is helpful. But if the blood pressure goes on increasing, then we need to add more drugs which are safer along with alpha-methyl dopa to have a better control of blood pressure. Well, if there is a severe hypertension and there are chances that there are development of organ involvement with the chances of preeclampsia, proteinuria, or even going in eclampsia for the seizure prevention should be done with the loading doses of magnesium sulfate, which is recommended for all severe preeclampsia cases, and the other drugs, antihypertensive drugs, for control of severe hypertension in these females are nifedipine, labetalol again, which can be given even by IV injections and infusions. Then hydralazine is other vasodilator drug which can be given even IV or IM for better control of severe hypertension when the blood pressure becomes very high in these pregnant women, and even nicardipine, which is again a calcium channel blocker like nifedipine. These are the 4 drugs which are approved for the management of severe hypertension in pregnant ladies in large number of cases. Well, it is not only the management of blood pressure during the pregnancy, but even the delivery decision, which is very, very important, although this is the domain of gynecologists and obstetricians who are looking after the patients. But the recommendations guidelines are that continue pregnancy for mild preeclampsia and deliver the patient at 37 weeks. And if there is a severe preeclampsia with severe proteinuria and organ involvement, then delivery should be preempted at 34 weeks. If there is an eclampsia, we should first stabilize the patients, control the seizures, and then deliver post-stabilization. And there are some controversial role of corticosteroids also, which are again recommended for women delivering before 34 weeks and elective cesarean before 38 weeks, where optional intramuscular dexamethasone or intramuscular betamethasone can be given to reduce the neonatal respiratory distress and can have a good delivery outcome, and those can be given. So these are the measures which are extra measures which should be taken, and the decision of delivery should be taken for the health of the baby as well as the mother. The management of eclampsia, when the patient is having a seizure, the seizure control, as well as all the measures with the magnesium sulfate is the safest drug which are used in eclamptic patients for the control of eclampsia. The Pichard regimen using 50% weight by volume ampoules of 1 gram each is preferred worldwide. And we should continue the magnesium sulfate for 24 hours even after delivery or last convulsions. And there is no routine serum monitoring which is needed because it does not cause much of a toxicity, magnesium sulfate toxicity. So this is the management of severe hypertension, preeclampsia and eclampsia, and the control of blood pressure. After stabilizing the patients, the delivery is recommended for eclampsia or severe pre-eclamptic patients or chronic hypertension. Usually, of course, vaginal delivery is preferred, but then gynae and obs, they take a call on this. The intrapartum care is required, and delivery mode depends upon many factors: the gestational age of the patient, the severity of the fetal growth retardation, as well as umbilical artery Doppler study, and many of the investigations which the gynae and obs they order for a better management of delivery as well as health of the mother and the child. For post-delivery management, of course, prostaglandins on mechanical methods are recommended for labor induction. Judicious fluid management is very crucial because these patients with organ involvement and pre-eclampsia and eclampsia are likely to go in pulmonary edema if we give excess fluid, and if we give less fluid, they all with the decrease in urination and of course the renal involvement and kidney failure. So meticulous judicious management of fluid is very important. IV fluid is very important. Close vigilance for post-delivery complications like PPH, postpartum hemorrhage, HELP syndrome, pulmonary edema, cardiovascular or cerebrovascular accidents, or thromboembolic issues. All these are to be monitored very closely by the clinicians for a healthy outcome of these mothers who are hypertensive during the pregnancy. For post-delivery management, the antihypertensive medications and regular visits for at least 3 months are very, very important to decrease the risk of chronic hypertension or any complication which is associated with hypertension like cerebrovascular accidents, kidney diseases, or impaired memory or thromboembolism. So these patients should be advised to follow regularly to the clinicians at least for 3 months for a regular checkup of their blood pressure and management. So proper planning and monitoring are necessary when transferring the patient to a better equipped facility, and it should be seen that the patient should not fall further sick during the transport. So my dear friends, with this, I would like to come to my last slide where I would like to emphasize upon a few points to summarize my talk, that good blood pressure measurement technique is essential for the accurate diagnosis of hypertensive disorder of pregnancy, as improper techniques are likely to falsely elevate the blood pressure and unnecessarily will go for the treatment which is not required for the patients. Initially, the diet control, lifestyle management with salt and fat restriction, with a regular walk and mild physical exercise are all essential parts to be emphasized upon for these patients. And then, of course, then the medication if it is needed. As far as the salt restriction is concerned, the Indian population, they are very sensitive, and it is advised that at least daily salt intake should be to the tune of around 2 to 3 grams only, and one should not use table salt, at least if one is likely to get or has got a family history or gestational history, earlier pregnancy history of hypertension during the pregnancy. They should very strictly follow the diet of low salt and then a regular exercise as well, which helps in better outcome even without medication. Then secondly, labetalol and nifedipine, they are the preferred first-line agents for the treatment of hypertension in pregnancy. Alpha-methyl dopa can also be used in the early stages, but it is not a very strong antihypertensive drugs. It needs a supplementation with the other antihypertensive drugs, which are safer to be given during the pregnancy. The postpartum hypertension is a leading cause of readmission. So naturally, after the delivery, these patients should be followed at a regular interval for a few months so that they do not develop a chronic hypertension and their blood pressure again is well controlled with the medication and of course with the diet restriction as well as lifestyle modification. Headache or visual changes in the postpartum women should raise concern for postpartum preeclampsia and they should be investigated for the same. The proteinuria is the hallmark with the kidney involvement, and that should be looked after very meticulously in the long run for a healthy life ahead. And finally, an accurate reproductive history taking is an essential part of a woman's medical record and should always be inquired about to appropriately risk stratify the women for cardiovascular disease and cerebrovascular accidents. So the history taking, the dietary advice, lifestyle modification, moderate degree of exercise, these are all part and parcel of the lifestyle of a pregnant woman to avoid the development of complication in these patients. And if we follow all these measures, we can provide a good, healthy life for these patients for a long term, as well as a good net and antenatal period or natal period, and then good delivery outcome for a betterment of the mother's health as well as for the child health. Now, with this, I would like to end my talk and would like to thank all of you for your patient listening. Thank you very much.
Thank you so much, sir, for your wonderful presentation. We have some questions from our audience if you'd like to take that up.
Yeah, sure.
Thank you, sir. So the first question is, are there any recent development in research or changes in the guidelines related to the management of hypertension during pregnancy that healthcare professionals should be aware of?
Yes, it has always been said that the control of blood pressure should be meticulous and it should be done with utmost care at the earliest part so that we can have a good control of the blood pressure. And of course, labetalol recently has come up in a big way for the control of blood pressure in these patients. The main advantage with labetalol among all the drugs is that it can be given both the routes orally as well as IV. So if the blood pressure is very high, we can control the blood pressure in these patients with IV infusion. And once it is controlled, then of course we can continue with these drugs during the pregnancy with oral preparations. So this has become the drug of choice. In comparison to this, earlier we were using methyl dopa in large number of patients, but with methyl dopa, the only thing is that now the availability of this molecule has become little difficult as it's not as frequently available as it was earlier. And secondly, it is the mild drug to be used, and then the uncontrolled blood pressure requires little more drugs to be added for synergizing the effect of methyl dopa. So labetalol has come in a big way. And the other drug, which is very, very good and effective and powerful, is of course nifedipine retard preparation, which can be used in large number of patients. So these two drugs have come in a big way, and alpha methyl dopa has gone little back.
Thank you so much, sir. So, sir, the next question is, what are the potential complications for both the mother and the baby associated with uncontrolled hypertension during pregnancy?
Okay, as I told, that uncontrolled hypertension in the pregnancy, that can increase the morbidity and mortality for both mother and the child. These patients are likely to develop the target organ involvement, which we call as the preeclampsia. As I have shown you in the pathogenesis, again, because of the involvement of proteinuria and the decrease in the podocytes, the renal involvement is very, very dangerous. And with that, the patient develops pedal edema, proteinuria, acute renal failure, as well as the patient may go in pulmonary edema. Then after that, even the further enhancement of the blood pressure complication, there is a development of eclampsia, where the patient goes in seizures. And with the seizures, there may be a preterm delivery of the baby, and the mortality of fetal mortality chances, they increase they become very high. Even with the development of severe hypertension and eclampsia, the baby survival of the chances of the baby become little less, and thus this is a very complicated. And then if there is a fetal death, fetal retardation, then the IUD occurs, and with the IUD, the health of the mother also becomes very risky, and it is to be controlled. So there are many complications in the maternal front as well as the fetal front that occur if the blood pressure is uncontrolled during the pregnancy.
Thank you so much, sir. The last question from our audience is, how do different hypertensive disorder during pregnancy impact neonatal outcome and long-term health?
Neonatal outcome and health.
Yes, sir. Neonatal outcome and long-term health.
Long-term health of the patient.
Yes.
Of course, if we are able to control the blood pressure to a desired level, then the chances of a normal delivery are enhanced. The mother's health also becomes importantly better, with a better outcome, as well as the fetal health also is at least it is stable. Now, after the delivery, the follow-up is also very, very important, as I emphasized upon, because there are chances of 5% of these patients to develop chronic hypertension in the postpartum period, and then they need to have a re-emphasize the lifestyle modification which is to be given to them, the diet control which is advised to them, as well as the regular medication for the control of blood pressure in their postpartum life and ahead. So naturally, if we control the blood pressure early and we advise them about the dietary restriction as well as lifestyle modification, it helps them. Similarly, even for the babies, for the newborns, for a healthy life, that because it's a genetic predisposition. So the child which is born to a hypertensive mother may also have chances of development of hypertension in the later life. So right from the beginning, it should be advised to the mother to take up lifestyle care, lifestyle modification, not only for herself, even for other family members, and particularly for the child when the child grows up. So for a healthy life ahead, we should emphasize upon again and again for a diet, salt restricted diet, as well as mild to moderate regular exercise, which goes in the long way for the control of blood pressure and having a good life ahead for the mother as well as the child.
Thank you so much, sir, for answering all our questions. Before concluding today's session, any last remark from you?
Yes, I know that I am also doing the practice in the hospital. The management of hypertension in a pregnant woman is always very challenging. So naturally, it is advisable for the clinicians to practice in such a way that they can provide these mothers, pregnant mothers, a good life, a good pregnancy, and a good and healthy child. And for this, at least we should update our knowledge about the recent advances, about the measurement, correct measurement of the blood pressure in these mothers, as well as the lifestyle modification, apart from the minimum possible medication which are required to be given to these mothers for a better control of blood pressure during the pregnancy. Then only we can provide a good life to these mothers and their babies. That is my message.
Thank you so much, sir, for joining us today. With your permission, I'd like to conclude today's session.
Thank you. Thank you very much for giving me this platform. And thank you very much to all my colleagues who have joined this evening. And I think they must also have taken